I would normally be doing this coming from the Kaweah studios, but we're doing kind of a different version of it. So you're going to go ahead and be the moderator again and ask the questions. And
yes, I will.
Okay.
Okay, so let's start off with a brief update. These are all people who are involved in the community, so we want to know about the projects that Kaweah has right now. We see an industrial park clinic on coming up. We see that if we're out in the industrial park. We know that you just closed on property at Sequoia Gateway, and we talk often about the Stanford partnership, so can you give us updates on those three?
Yeah. Well, no doubt about it, these continue to be incredibly challenging times for hospitals across the country, particularly hospitals in California, and we're no exception here in Visalia at Kaweah. But despite those challenges, still a lot of exciting things going on. We continue to grow and evolve as an organization, try to be responsive to the feedback that we get from the community in terms of perceived needs, healthcare needs in our community, and trying to be responsive to that. So definitely a lot of growth going on in Northwest Visalia, the industrial park in particular. I'm very excited to see some renowned businesses come into Visalia from an economic development standpoint, new jobs and so forth. So that led us to develop a clinic in Northwest Visalia, very close to the industrial park, that will, one of its primary services will be to provide occupational health medicine, as well as pre-employment screenings and so forth to support the businesses and their workers out there. But that clinic will also be staffed with primary care physicians, advanced practice providers like nurse practitioners and PAs that can be the primary care site for the people that live out there in the Northwest Visalia, including those employees that are working in the industrial park. Be very convenient for them while they're on shift to be able to come over and see a doctor for an appointment, you know, on their lunch hour or break, something like that. So we will also provide scheduled primary care visits there, as well as walk-in, like urgent care. So we are probably 3 to 4 weeks away from finishing construction, but then we will have to stock and staff, equip and so forth, and then we will have to undergo state licensing survey by the California Department of Public Health. So we're thinking that we'll probably see our first patient in the second week of September. So very excited about that clinic. We're recruiting right now for the providers, recruiting for the clinic manager. All of our clinics across the Kaweah Health system will generally have a site manager that's overseeing the day-to-day operations. So recruiting that position right now. Yeah, Bruce?
Have we established the normal operating hours, days, and times?
Not yet, not yet. Yeah, that as we get closer, we'll probably announce the completion of the construction and us taking formal occupancy, and at that time announce, you know, when it will open and the hours and so forth.
And for after hours, do you see any way that it could stay open?
Yeah.
You know, second shift?
Absolutely, yeah. So we our urgent care centers, you know, on Demery and Court, they run after hours. I think Court's almost to like 11 o'clock at night. I think Demery might close sooner, but I think they'll be after hours and weekends, at least Saturdays, probably will be available.
Is this just for commercially insured?
No. We also will invite Medicare. I don't know yet about Medi-Cal because Medi-Cal pays so poorly in a community clinic, but they pay well in a rural health clinic. So we operate 5 rural health clinics. We don't currently have one in Northwest, but we just had a meeting earlier this week to explore other potential sites for rural health clinics that would really focus on that Medi-Cal population. I don't know if there's one that's immediately proximate to that one, but I think within, you know, a fairly close range of it. So, yeah. Sam, did you have a question, or Steve, or?
I pulled up my notes from 19, our first meeting, and you had a whole bunch of random facts about Kaweah. And we had 4 clinics then, so Tulare was the 5th clinic?
Yes.
And this will be the 6th clinic?
Well, we have 5 rural health clinics, but we also have the Kaweah Health Medical Clinic on Ben Maddox and Tulare. It was formerly part of our VMC Medical Foundation enterprise, but when we parted ways with Visalia Medical Clinic on April 30th, Kaweah took back that clinic, and it's been renamed the Kaweah Health Medical Clinic. Dr. Bill Roach is the medical director. We actually just added a pediatrician to that clinic, and we'll soon be announcing her availability. But that clinic also provides primary care and walk-in care. We have a clinic on Cherry Street in Tulare. Dr. Sarmad Saeed is a full-time cardiologist that practices in that clinic. And then here on our West Campus, just over my shoulder, is the Kaweah Health Cardiology Clinic. And that's staffed by Dr. Ankar Gupta, David Sislowski, Harry Lively, Dennis Johnson, Dr. Singla. Very, very busy cardiology clinic. Has a full diagnostic center that does echocardiograms. We do cardiac PET CT in that center. So those are also clinics of Kaweah. So yeah, we've grown quite a bit beyond the 4. So this will be, and we also have what the Kaweah Health Center for Mental Wellness just opened, and that's over on Noble and Encina. And that is also for the Medicare and commercially insured population, where we have LCSWs, marriage and family counseling. So actually, that's the one area of mental health services that the Medi-Cal population has much more extensive access to outpatient mental health services than the Medicare or commercially insured population. And so we specifically developed that mental health clinic to serve, that population. So, yeah. The Stanford relationship, very excited about that. It is formally now in place. We signed an agreement, so we now have a formal partnership. Dr. Joseph Wu, who is the chair of cardiothoracic surgery at Stanford Health. I've met with him several times now. He is world-renowned in cardiothoracic care. So the relationship with Stanford, and I'll talk, I was asked this recently, help me understand the difference between Cleveland Clinic and Stanford Health. So you may be aware that a number of years ago we entered into a formal partnership affiliation agreement with the Cleveland Clinic. The Cleveland Clinic has been ranked #1 in the country in cardiothoracic surgery for the last 28 years by health grades. So Kaweah ranks in the top 50 in the nation. There are 1,200 hospitals that do open heart surgery. We've been named in the top 50 now for 6 years in a row. We are ranked #2 in the state of California, behind Stanford Health, who's ranked #1 in California. But Cleveland Clinic's been #1 in the country for 28 years in a row. We actually engaged them a number of years ago. They have a consulting arm, so we engaged them to come on site and to assess our cardiovascular program. So not just cardiac surgery, but also cardiology, and to help us be more efficient, institute best practices, things of that nature. They fell in love with us. They said, this is an awesome program. We had no idea that you had this caliber of a cardiac program here. We have an affiliation program. We have 16 different affiliates across the United States. We have one with Sequoia Hospital in Redwood City. We would love for Kaweah to be our second affiliate in California. And so we did that. We entered into a kind of a long-term agreement with them. It more than pays for itself because we were able to access all of their vendor agreements to acquire implants like pacemakers and stents and valves and things of that nature. So just in the first year, we had about a 2-to-1 return. But the reality is, those of us in healthcare know who the Cleveland Clinic is, but many people in our community have no idea that it's this renowned hospital, health system. Even though it says clinic, it's kind of like the Mayo Clinic. You know, it's not a clinic. I mean, they have clinics, but Mayo, Cleveland, they're, you know, again, renowned health systems. But to this day, we have never sent a patient to the Cleveland Clinic. We've never referred them. But they get referred to Stanford and Cedars-Sinai and UCSF, and that's where our cardiac surgeons or our cardiologists would send them to Stanford before they go to Cleveland Clinic. So that affiliation with the Cleveland Clinic will expire in about another year and a half. And so we're not going to renew it. So I don't want to confuse the public. So we will be co-branding with Stanford. So you will see Kaweah Health and Stanford. It's a bit different than what Stanford typically does. So Stanford was running the cardiac surgery program at St. Agnes, but it was Stanford's program. It was not St. Agnes. It really was Stanford was there running the program, and it was their program. With Kaweah, we are their partner. This is our cardiac surgery program, but they will be recruiting cardiac surgeons into the Stanford Health Medical Group, Cardiothoracic Medical Group, and they will place those surgeons in our community. Those surgeons will live and practice and be a part of our community. They will be part of the faculty. They'll be on staff at Stanford, so they'll get all the benefits and the support of the Stanford Cardiothoracic program, but they will be our physicians here in our community. I'm excited to announce that we have signed on our first Stanford cardiothoracic surgeon, so Dr. Michael McLean has joined us. Again, he first joins Stanford, but now he will be here likely in September. And then we are recruiting 2 additional cardiothoracic surgeons that will join Dr. McLean. So when we're all done, ideally in time to say goodbye to Dr. Mayer, who will be retiring at the end of this calendar year. Although Dr. Mayer asked me, he goes, do you think I could hang around and fill in shifts for them when they, absolutely. Dr. Mayer is an outstanding cardiothoracic surgeon as well. So he'll continue to live in our community, be a part of it. So we're very excited about that. And then yes, the Sequoia Gateway project, which is the project out on Caldwell and Highway 99. Unfortunately, we heard that the Great Wolf Lodge has pulled out of the deal. I think it's kind of just because of COVID and everything is hunkering down, kind of focusing on their existing properties and curbing their development for right now. But we purchased 7 acres of land in that development. That escrow is now closed because there was a ditch that kind of cut through our property that we needed straightened out so that we can fully develop our 7 acres. So that took a long time to do. They had to make special concrete pipes that would fit down in the ditch. So once that was done, we were able to close escrow. So we are now working with a developer. I think he's out of Southern California. A developer as well as local investors. So we've had a number of kind of prominent people in our community that are very interested in being a part of that development project, would like to invest in it. And so we are exploring the development of a new ambulatory surgery center that would have as many as 12 operating rooms and 2 cardiac catheterization labs. We might ultimately also build a medical office building, but we're first going to focus on the ambulatory surgery area. That is the fastest growing area in healthcare these days. More and more surgical procedures, cardiac procedures are moving out of the inpatient hospital really into ambulatory surgery centers. You literally, next door at Kaweah Surgery Center, you can get your hip or your knee replaced and go home the same day. That never used to happen in the past. It was generally a 2, 3, 4-day stay having a joint replacement. So you'll continue to see that occur, and we want to be a part of that. We actually are investor owners in Kaweah Surgery Center now. That's a joint venture that was created, what, 25 years ago, Dean? I think it was?
It opened up in 1994.
Wow. So Kaweah owns 30% of that, and our surgeon partners own the other 70%. But that facility is old, 20-something years old, and I think our physician partners are looking for something newer, more modern, definitely that has more capacity, particularly that 99 in Caldwell, interchange there, high traffic area. So would have ample parking and move, that out, because we do a lot of outpatient surgery downtown in the acute medical center. So moving that out to that Caldwell 99 site will create more surgical capacity on the inpatient side for us as well. So Valley Children's Hospital owns 6 acres of land in close proximity in that development. We've been in discussions with them ever since they bought it. What we'd like to do is kind of similar to what they did in Fowler, right there on 99 with Adventist Health, that we would create an adult rural health clinic, and they would create the pediatric, probably mostly specialty care. They're not really into the pediatric primary outpatient care. They kind of leave that to community pediatricians, but they would focus on the specialty care. They lease space across Mineral King right now on the corner of Mineral King and Acres. You see the Valley Children's Medical Group, but they've outgrown that, and so they would like to develop on that 6 acres. So I would probably said that that would have been several years out, but healthcare is increasingly competitive, as you know. Obviously, with Adventist Health partnering with Visalia Medical Clinic, that creates a more intense, competitive situation with them. And so we want to accelerate the development of that ambulatory surgery center, but we don't have the capital to do it. So we have the land, and so we will be part of the joint venture that operates the surgery center, but we are unlikely to own. We won't put up the capital to build the surgery center. We will leave that to the developer and local investors. Physicians will likely want to invest in that, but we're going to preserve our capital. But we'll either do a 99-year ground lease of the property, or we would sell the property as perhaps our investment in the operating joint venture. There's a lot of other exciting things going on, but I know I have other questions.
Okay, all right. So thanks for clearing that up, because we do get a lot of questions in the community, like how are you affording to expand while you're in financial distress on this end? And so just to clarify, when we build out at Kaweah Gateway, we will be leasing, investors will be fronting the capital.
Yes.
Industrial Park
Yeah, and
Clinic as
that's
well.
the same for the Northwest Clinic too. So the only clinics that we own in the whole Kaweah health system is the clinic in Exeter and Tulare. So our clinic in Lindsay, Woodlake, Dinuba, what will be the Northwest Visalia Clinic, the cardiology clinic, those are all leased. So we didn't put up the capital to build them. So we lease them, which is much more cost effective for us, and the reimbursement and revenue that we generate from those services more than covers that operating lease and creates a profit for the health system. So yeah, thank you.
Okay, thank you. So we're getting ready to go into the financials. We want you to review the May financials with us. But we've repeatedly talked since the beginning of these webinars about our staffing issues. When COVID hit, we had a lot of staffing issues. We had traveler costs. first of all, have those costs leveled out, has our staffing leveled out, and then if you could just kind of give us a brief review of the May financials.
Yes, so I will say things have gotten better. They're not great by any means. The hospital industry is still suffering one of the worst workforce shortages, most severe that I think any of us have ever experienced. We lost 100,000 registered nurses, dropped out of the profession over the course of the pandemic. An article I just read recently is that this country will need 425,000 new registered nurses by 2025. 425,000. We're doing a lot. I think you've heard about our relationships with College of Sequoias, San Joaquin Valley College, now Unitech. We are working with all of those institutions to increase the number of nursing slots. And they've been great to work with. Jana Schengel, and she has really gone to bat to increase the capacity of the College of the Sequoias. Not just straight RNs, but LVN to RN bridge programs. And when these three programs hit on all cylinders, we will be producing, we will be graduating 150 RNs every year that will be very focused on Kaweah. And actually, in most cases, will have an obligation to work, a contractual obligations, because we're helping fund their education. So they, in exchange, agree to commit to so many years at Kaweah. And hopefully they fall in love with Kaweah, they fall in love with Visalia, and they make this their permanent career. So, but today, we still have over 500 open positions at Kaweah, 524. Now, 172 of them are RNs, 48 LVNs, and 24 certified nursing assistants. And that's not uncommon. Virtually, again, every hospital, it's even more severe in the Central Valley. We've always been at a disadvantage in terms of attracting, skilled healthcare workers than the more metropolitan areas, Bay Area, San Francisco, or LA, and so forth. But those 524 positions really cut across the entire organization. Accountants, housekeepers, dietary workers. I heard this morning we're down 10 security officers right now. So, and unemployment is below 4%. So it's just been very, very difficult to attract that skilled labor here. Now, that said, we have seen some easing on the dependency on nurse travelers. So at the height of our dependency, which was back in September of last year, we had 240 bedside traveler nurses that we were paying $200 or more an hour. We were consistently, every single month, spending $8 million on traveler nurses and not getting a single penny in additional reimbursement from any of the payers. So that's really what's caused the greatest financial challenges to hospitals, is that dependency on very, very expensive contract labor. Just since the beginning of the pandemic, so really March 2020 through the end of May, we have now spent $123 million on contract labor. Literally all of that funded out of our cash reserves to cover it, because we have not been profitable in any year throughout the pandemic. Adventist Health, large, multi-hospital health system with a presence here in Tulare and Kings County, announced just last month that they'd lost close to $350 million last year, and the year before lost $270 million as a system. Common Spirit, who is the largest religious-based health system in the United States, posted a $1.3 billion loss last year. The Cleveland Clinic posted a $1.2 billion loss. So we're in good company, not company that you'd want to really celebrate being in. but so much of it being fueled by those high labor costs. Fortunately, today, we are down to 72 bedside traveler nurses. So it went from 240 to 72, and the rate has come down from 200 to about $115. So we are now, for the last 4 months, we're spending 2 to 3 million on contract labor versus that 8 to 9 million that we were spending every month back at the beginning of the year. We will continue to need to use contract labor. It's not going away. Many hospitals like Kaweah are now implementing what's called team-based nursing. So historically, particularly in California, California is the only state in the country that has nurse staffing ratios that are set by law. So in a California hospital on a typical medical surgical unit, an RN cannot take care of more than 5 patients. On a telemetry unit, it's 1 to 4. In the intermediate critical care units, it's 1 to 3. And in the ICU, no more than 2 patients per nurse. And if you don't abide by those regulations, you're fined $30,000 a day. So California is the only state in the nation that has those mandated nurse staffing ratios. Texas, I mean, there are guidelines in other states, but Texas is 15 to 1. 15 patients to 1 RN. Nebraska is 12 patients to 1 RN, which is probably why the nursing availability is so scarce in California. We just don't have enough nurses. So now we are creating teams where an RN, an LVN, a CNA are taking care of, say, 6 patients or 7 patients. So that RN, you get to count LVNs in meeting those nurse staffing ratios. So it does allow you then to be able to meet the patient demand that we're facing without having, every one of our nurses in those ratios being RN. They're very capable of LVNs. They're operating at the height of their scope, their licensed scope. They can't do everything an RN can do, but they can do a lot to support that RN. So still providing very safe, high quality care.
Gary, I've got a question on that.
Yeah.
And this might make Dr. Levitan roll his eyes because it's just an uninformed question. How would they know? How do people know?
So they randomly, the California Department of Public Health randomly sends surveyors here just to go up on the floors and check your staffing logs. And we have employees that call the state to tell them if we're out of ratio. Yeah.
Gary, I had a request or a question from somebody that's going to school, and a phlebotomist versus an MRI tech, how are they compensated? Are they part of the shortage of staffing?
They are.
Is one paid more than the other based on the number of hours or years in school?
Well, it's more, Sam, it's more market driven. And a phlebotomist versus an MRI tech or an OR tech or an ED tech, I would imagine they're all in a fairly narrow band, the technical position. But a lot of it is supply and demand. So clinical lab scientists and phlebotomists are very scarce right now. And so that will drive up the market price. So everybody's throwing more money after fewer phlebotomists to attract them to their hospital. So that then drives up the market wage for that position, and you've got to meet that. So a lot of it is driven by supply and demand. If we had abundant supply, then it could be influenced by their skills, the technical knowledge that they have. Could be, how many years did they go to school? Nowadays, like a pharmacist has to have a doctorate. A physical therapist now has to have a doctorate to be a physical therapist.
With the nursing ratio, is there any potential for the state to apply to have that ratio changed?
Never.
Never.
Never, no. It's all driven by the SEIU and the California Nurses Association. The unions are very, very powerful in California, in healthcare as well as many other industries. And they have great influence over the legislature and over the governor. And I can't see that ever backing off.
And then, any progress on getting a hepatologist locally?
Yeah, Dr. Havard, who leads our oncology. So generally, although I might think of hematology, he said hepatology, which is blood conditions, right?
Liver, hematology, I apologize.
Hematologist, yes. So Dr. Havard is both an oncologist and a hematologist. And so, but he's kind of ramping back a little bit and he'll go part-time, but he is recruiting for additional oncologists. And typically we're recruiting for somebody that is board certified in both oncology and hematology. Yeah, I don't think we have them here yet. Yes.
I was just gonna ask, I'm new to California, but I was wondering how long those ratios have been in effect. And then the other question would be, when they passed those, when the legislatures passed those laws, did they offer solutions to? Because it seems to me like they created the crisis that we're in now. And why wouldn't they think of solutions when they were passing those laws?
Right. We call those unfunded mandates, which our state is notorious for passing that kind of legislation and imposing it on not just hospitals and not just our industry, but I would say nurse staffing ratios, gosh, probably in California have been in place a couple decades. They've been tightened over the years. They were looser when they were first put in, but now they've been tightened. The nursing unions would like to see them be even tighter. The more nurses, the more union members, the more dues you raise. And so, I don't think their motivation was all behind safety and the quality of care, but that's all you hear them talk about. But they put it in place with zero increase in funding for hospitals. In fact, I've been a big advocate in Washington and Sacramento over this last year. Hospitals in California have not received an increase in our Medi-Cal reimbursement rates. On the inpatient side, it's been 14 years since we last received an increase, and on the outpatient side, so if you're doing a joint replacement on a Medi-Cal patient or a colonoscopy or something of that nature, we get paid the same rate that we did 30 years ago, same exact rate under the Medi-Cal fee schedule, and yet they implement. So I'll jump ahead because it's kind of related to this. So Senate Bill 525, California Chamber of Commerce just came out and designated it as a job killer, this bill. So this bill put forth by the SEIU would require that all healthcare entities implement a minimum wage for all healthcare workers of $25 an hour. That's not just for hospitals, that's for doctors' offices, ambulatory surgery centers. So your housekeepers, your dietary, everybody, a minimum of $25 an hour. The state or the California Hospital Association estimates that will cost California hospitals $8 to $10 billion a year. It will cost Kaweah $25 million a year. They did make an amendment that instead of $25 an hour on June 1st, 24, they're going to start with $21 an hour on June 1st, 24, and then raise it to $25 on June 1st, 25. There is zero funding that is coming with that. The unions have convinced the legislature and the governor that California hospitals' coffers are bursting at the seam. That, don't believe what they're telling you. Hospitals have made so much money over this pandemic. They coded every single patient, a COVID patient, and they get paid 2 to 3 times higher for a COVID patient than a non-COVID. I assure you, none of that is true. On April 1st, 2020, Medicare temporarily increased the reimbursement rate for a patient that has severe acute respiratory distress or disease, which is essentially what SARS-CoV-2 is. They increased the reimbursement rate from $14,000 to $16,000. But our cost of taking care of a patient went from $13,000 to $30,000 if you had COVID. So we lost tremendously on every COVID patient we took care of. But the unions have convinced the legislature and the governor. Sadly, that bill already passed the Senate. The state Senate already voted on it and passed it. And so now it will go to the Assembly. Everybody in this room should fear that, because not only will it impact hospitals and healthcare and access and the cost of care to consumers, but now think about if you own a restaurant here in town, or a grocery store, or a hotel, or any retail outlet that employs housekeepers or wait staff, or are now going to demand $25 an hour, or I'm going to go work at the hospital where they are mandated to pay me $25. That's why the Chamber of Commerce has come out and called it a job killer, is because it will affect multiple industries across California. So if you want to write to your assembly, write to the governor, right? I know, Devin Mathis, Shannon Grove, our assemblyman and state senator have already wrote letters of opposition, but we need Senator Hurtado, who I'll be meeting with I think next week. We need the Democrat coalition to oppose 525 as well, but it's got a lot of momentum right now. Yes, sir.
I'm curious, what's the greatest demand for physicians as far as recruitment over the next year or two, as far as what's the greatest number of specialty that you see Kaweah needs? And also, does Kaweah ever consider tuition reimbursements? I asked selfishly, my son's in his fourth year of medical school, he's going to be doing his rotations here, but I was just curious, will there ever be a tuition reimbursement opportunity? I mean, that's not a very good question.
No, we do that now. So, we have our own residency program. We have 6 different residencies and 130 residents. They are, while they're in residency, they're Kaweah employees. And we pay them a salary and benefits and everything while they're in residency. When they graduate, we recruit. And when we recruit physicians, we offer income guarantees as they start ramping up. But we also offer loan forgiveness. So it's kind of like those nurses I was describing. We'll enter into a recruitment agreement with that physician, and we'll provide, we might give them a 5-year loan forgiveness, pay their student loans for 5 years or 3 years. But in exchange, they have to commit to stay and work in our community for so many years. But that loan forgiveness is relatively new, just in the last few years, but now it's the norm. Kids are coming out of school, doctors coming out of school with, so much debt now that we help them. And it's usually $100,000 to $200,000 a year that we're providing in that loan forgiveness. Yeah. So gastroenterology is always at the top of the list. Urology, which is why we actually, like Stanford, we have a formal affiliation with the USC Keck School of Medicine. Dr. Indy Gill, world-renowned in urology. He heads their program, and he's been here to Kaweah and Visalia many times. So he's helping us recruit urologists to this community. But interesting, primary care, family medicine and internal medicine. And the pendulum swings on that. A lot of medical students aren't going into those professions. Unfortunately, they're some of the poorest paid among the different physician specialties. And so a lot of them now want to become hospitalists. So they don't want to go into outpatient practice and have to take after-hour call, and it's a lot of hard work being a primary care physician. Rather, I could just go be a hospitalist and work 7 12-hour shifts, and then I'm off for a week, and I get a guaranteed salary, and when my shift ends, I go home, and phone never rings, and so we're competing with, because we need more primary care that are available to all of us in practice. We've been helping Visalia Family Practice, Dr. Rodarte and Dr. Tates, and they've been trying to recruit for 2 years to bring more primary care in, and they can't find them. So we're partnering. Our recruiters are working to help them. So, Dr. Levitan, any others that come to mind, or?
I would say that is probably the most, one thing I wanted to mention though is that sometimes it comes up that not as many of the residents stay in the area as may have been hopeful. And I think in part that's because residency has become not an end in itself. Many of the residents for training are going on to have fellowships.
Right.
And they therefore wind up finishing the training not in Visalia, but somewhere else. Whether they come back to Visalia is unclear. So I think that's part of the reason why the residency program hasn't yielded the community-based physicians that maybe had optimistically been hoped for.
Well, it's been disproportionate. I just welcomed 47 new interns. The class of 2023 just arrived. Their first day of their residency was Monday. But last week, we graduated 47 residents. And Dr. Levitan's right. It was disappointing to hear how many of them were going on to do a fellowship someplace else in the country. And maybe they'll come back, not necessarily. But up until with this new graduating class, we've still retained 42% of those that graduated, which we went into it thinking anywhere from 30 to 50%, but the literature said would stay. So we're kind of right in that middle, but it's been declining. We had our big wins. We just celebrated our 10-year anniversary when we launched the residency program. And we've kept way more than 50% of psychiatry stay, but family medicine, emergency medicine, many of them leaving our community. So yeah, we did start a child and adolescent psychiatry fellowship program, and all those slots were filled by our psychiatry residents. So Dr. Levitan's right. They want to go into a fellowship to get special training, and when it's not available here, they have to go someplace else. So as soon as we put that fellowship program in, they stayed. So whether we'll develop more fellowship programs down the road.
I think neurology is a fellowship program that may work.
Yeah, at first we got to start a neurology residency program, and Dr. Dick Pantera is really leading the charge there. That would be another one I would add to that scarce list, neurology. I'm really worried that when Dr. Pantera retires, although he retired from private practice, but he is fully working in the hospital with the psychiatrists, working with the neurosurgeons. So we are really recruiting for neurology as well. Okay, May's financials you said to talk about. So it was kind of a mixed bag. I'll do it from memory. We incurred a $1.7 million operating loss in the month of May, far better than the $8 million operating losses we incurred in July and August, and then the $12 million loss we experienced in September when we had that really high contract labor expense. So you wouldn't normally celebrate a $1.7 million operating loss, but it's going in the right direction. But what you don't see until you look under the hood is that we actually would have had a positive operating margin for the month of May had it not been for 2 adjustments we had to make. So we are self-insured for malpractice up to the first $4 million of a claim. And so we have to engage an actuary every year to come in and assess all of our, any, malpractice claims that have been asserted against the hospital, as well as what possibly could be asserted within the statute of limitations. And so they estimate what that ultimate liability will be. Well, they increased the liability greater than what we had on our books. And so we recorded about a $1.5 million additional expense in May that really doesn't belong to May. Similarly, we have a defined benefit pension plan that we froze back on June 30, 2011. So no additional benefits are being earned. Nobody can enroll in it anymore. We have a matching 401k plan. But we, again, have to employ an actuary to calculate the ultimate pension benefits that we'll have to pay out. And so now you're taking into account how long are people going to live and draw down on that pension because it's a lifetime pension. There's a surviving spouse version that you can, so then you got to project how long would the spouse live as well, and so you need actuaries. Well, I don't know if lifespan increased slightly. It doesn't take much. It's a $300 million plan, but that also, that expense went up. So between the two of those, we recorded about $3 million in additional expense in May that you could argue didn't belong to May. And so take those out, and that $1.7 million loss now becomes like a $1.6 million profit. So that was very, very exciting to see that. At the same time, you also, we ended our relationship with Visalia Medical Clinic. We owned all the assets, all of the equipment, the furnishings, the computer system, the staff, and we sold it all to Adventist Health, and we sold it at a gain. So there was about a $6 million gain on the sale of those medical foundation assets. So that was all recorded in May. It's not part of that operating margin because it's considered down, it's below the line, but it still counts towards our bottom line net income. And so when you count that, even with those two adjustments I mentioned, the bottom line was in the black by several million. Now, we will still end the year with probably a $40 million plus loss. Because even though the last several months have been better, we haven't been able to recover from those first few months of the fiscal year. So we'll end in the red. We budgeted for an $11 million loss, but we'll end much greater than that. We will be out of compliance with our debt covenants. We have seen our cash reserves start to build back up. So we're at about 77 days worth of average daily operating expenses. So it costs $2.5 million a day to run Kaweah. And so you have to have a certain amount of cash reserves to cover, so many days. Our bond documents require that we can't fall below 90 days or we're out of compliance. So at 77, we're out of compliance. We were at 62 days at March 31st, and things were not moving in the right direction, but they're starting to rebound now. We probably will budget an operating loss next year. We'll actually propose the budget to the board next Wednesday. Our fiscal year starts on July 1. I don't know who maybe I was telling Sam or Bruce this, but we're definitely not out of the woods yet. When you think about, crawl, walk, run, I'd say we're still crawling, and it still feels uphill. But we'll get back on our feet. We'll start walking sometime during this next fiscal year, but it's still going to take a while for Kaweah and again, other hospitals across the country to fully recover. The state's got to do something with Medi-Cal reimbursement. I mean, nobody's hit harder than Kaweah. We have the highest Medi-Cal enrollment in Tulare County of any county in the entire state. 60% of our Tulare County residents are on Medi-Cal. Another 20-something% have Medicare and Medi-Cal. So they're both elderly and poor. So that's 60% have Medi-Cal as their primary insurance, but then another 20% have Medicare and Medi-Cal. So it's difficult to be profitable in Tulare County. Assembly Bill 869 being proposed by Assemblyman Wood out of Healdsburg. AB 869 would would provide a 5-year extension from 2030 to 2035 for rural and district hospitals only. And after that 5 years, if a hospital is still unable to fund its seismic replacement, then they will be indefinitely exempt from the seismic standards until such time as the state provides the money to build the hospital's replacement. So it means, so this bill has already gone to the Senate and passed 20-0. So no opposition. The unions haven't come out against it, although the unions have fought every other attempt to get seismic relief because there's $240 billion of construction projects for all California hospitals to become compliant. Those are great union jobs, those construction projects. So they fought it, except when it narrowed to just rural hospitals and district hospitals, because there are only 33 of us out of 400 hospitals are district hospitals. They really haven't, put up any opposition. They're not even talking about it. So we're hoping that it similarly flies through the assembly and then gets signed by the governor. It doesn't mean that we don't need to replace the Mineral King Wing. I think everybody on that Hospital of the Future committee agrees with that. That facility is, opened in 1969. It's not great, but this gives us a lot more flexibility and time to rebuild, and so it's a good thing.
So when will we know when that is officially approved?
I think all the bills have to go to the governor by September if they're going to be signed into law. So it's making its way. It's with the Assembly Healthcare Committee right now. So first a bill goes into, an assemblyman or a senator will put forth a bill, and then it goes through various committees, health, appropriations, before then it goes to the floor of the Assembly or the Senate. This bill, AB 869, first has to be voted on by the Assembly, because it's I think, is that right? Maybe it was a Senate bill. But yeah, so it goes through both houses. Kind of like you see the House and the Senate in Congress has to pass through both, so.
Okay.
Yeah.
All right. Are there
Well,
any
I'll
other
come back and
questions?
finish. Yeah, this has been great. I
Yeah.
appreciate all of you joining today, and I appreciate all the great questions, and would love to provide you lunch again and answer any other questions you have.